Okay, so I believe there was a couple of questions on the chat. You want to look at those while we're reading?
Okay, Haley, I'll take a look.
Just gonna fill these. Are those your new ones?
She has to pick it. I don't know the answer to that. You can, because health information is protected even from your spouse. It would depend on the last name of the baby. Are you kidding me? Sage. That's the weirdest name ever. Okay. Yeah. Yeah, I'll have William get on there. Yeah. ready? Well, I know, but you can't ever dispute a lab. Well, I do, but I'm telling you that test will save you from, they're trying to come at you in the future. Okay. Right. Text her, I mean, she's on vacation, but text her. She used to. Alright. Alright. My brother, so my brother was trying to get divorced, you know, and Serena got pregnant. And they couldn't get divorced because in the state of Oklahoma, you can't divorce pregnant. He thinks the baby's gonna test positive for drugs, like I guarantee it will test positive for marijuana. But he's like, since we're still married, can I call up there and find that out? I said, no. It's still protected, even from your spouse. And she named the baby Sachel Hayes.
Where did she hear that from?
It's probably the name of the read. I'm gonna see if I can see it on Facebook.
Sachel. It sounds like she put two things together. Oh, shoot, thank you.
Alright guys, I think that's about 5 minutes. We got a lot to cover yet. So, a couple of questions on the group chat, primarily about the assignment. Okay, so I don't, it says can it be at least 4 days or more? I don't think that there have been too many assignments that have been due since the very beginning of class. Like at the beginning, I did put a quiz one day on there and say it had to be done by the end of the day, but it was being counted for attendance. And since we're not doing that for attendance now, I believe that all of us are giving you time to do it. Ms. Briggs assigned hers the first Tuesday of her lecture of her inspection, and I think she gave till Saturday. I'm assigning today, and we have till Tuesday. That's like 5 days and 6 nights. So Ms. Chester usually does hers the same way. She assigns it the first day of her lecture, and it's like due usually on Saturday or the day of a test or something like that. So I don't know that we're not giving you adequate time to do that. So I mean, as far as I know, and what my brain tells me and what I know to be true as far as how instructors are assigning them, typically you're given several days to do that. So I don't know that that's an issue. Another one, hold on, let me get us. As far as head circumference of an infant, I can't really give you head circumference because a 4-pound baby's head circumference is going to be different than a 10-pound baby's head circumference. So there's no normal head circumference of an infant, right? The main thing is there a change in head circumference? Does it get bigger? And it may get a little bit bigger because initially you may have some compression of the sutures, right? And then as it relaxes and as the overriding sutures from the delivery come out, and it may relax a little, the head may get slightly larger, but we're looking for big changes over the days that they're there. So, and as far as can we have a set day every week? Well, again, if we do a set day, that kind of doesn't allow us to give you a certain number of days to get it done, right? If I were to say, because I'm really late, like I said at the beginning of the lecture, behind, and I didn't have this assignment ready to go. I wasn't sure which one I wanted to give. I had to go through all of them on these 3 different chapters to see which one I wanted you to have, that I felt was the most useful for you. I didn't have that on Tuesday. If I say that all assignments are due on Friday, and then I don't assign it until Thursday, that only gives you 1 day, right? But if I assign it on Thursday and say you have until Tuesday to do it, that gives you time. Whereas Ms. Briggs gave hers on Tuesday, and she says hers is due on Saturday. So that's why it varies. I can't give you a set day that they're due.
I totally understand on this height though, but I think the problem that we had is that we didn't, I know a lot of people didn't get that assignment on Tuesday, even via Zoom. I don't remember her announcing it on Tuesday, and then it was due Thursday night. And then Ms. Chester's are usually due on Saturdays. So I know a lot of people in our class assumed that the one that was assigned by Ms. Briggs on Thursday was due on Saturday or Friday. But then it was really due on Thursday night. So a lot of people didn't do it this week because of just the confusion of when it was due and who's due on what day and how long. Like it's confusing.
I think one was due like at 5 p.m. or something, which
Yeah,
none of the others were due at 5 p.m. ever, I don't think.
Yeah.
The weird time.
And that might just be a glitch in this week, what happened, or last week, whatever it was. So this may be nothing. It may just be confusion. I don't know. But I understand what you're saying about, not having a set day because of how. Yeah.
So anyway, I don't know how to fix that. All I can tell you is I would probably ask the first day of a lecture, do we have a short half assignment for this lecture, and when do you want it due? If they don't tell you, be sure and ask. Okay? I got asked on Tuesday, and I said I don't know yet. So ask and see what they are willing to do. That's the only thing I know to do, Haley, is just to ask for clarification. That's your best bet. You don't know something, ask. Okay. Neuro 2 to 6, 310. Guys, we got a lot of stuff to cover, so I need to hop to it, Skippy. All right. So this is a group of birth defects that have malformations of the brain and spinal cord. There's a picture. There's several pictures. And it's a lack of protection of the soft tissue of bone, spina bifida, myelodysplasia. Ooh, I said it. No two people are affected the same. And spina bifida looks different in everybody. And the cause is usually environmental and genetic risks. This is the one where we want the moms to take the prenatal vitamins before they even get pregnant so that they have the adequate amount of folic acid in their diet. If they know they want to get pregnant. So we know that's an environmental, that's something that we want them to make sure they're ingesting and taking enough of. Spina bifida occulta is the mildest form, and typically there's no treatment necessary. And then you have a meningocele and a myelomeningocele. Those are your different types of spina bifida. Varies depending on the level of the lesion and the defect. So if you look at your picture on page 1310, it kind of shows you what the different types of spina bifida look like. It shows you what a normal spine looks like. And I think our next slide does too. And then the meningocele is just a small, and then there's a picture of the baby as well. So it's just a small opening of the skin and the tissue that protrudes out. And then a myelomeningocele is when it's not just fluid, but it also contains nerves and parts of the spinal cord itself. A lot of times there can be weakness, paralysis, sensory loss, loss of ability for bowel and bladder control. With severe spina bifida, there'll be neurodeficits, hip and joint deformities, and again, that impaired bladder and bowel. Here's a picture. I really like the one in the book. It does show what a normal one looks like, and then it goes to spina bifida occulta, and it shows you here, right here. See how there's a bone here that protects the spinal cord? The spina bifida occulta, see how there's no bone in this area? There's no protection of the spinal cord right here. And then here we have just fluid in the meningocele. Cerebral spinal fluid in a pocket, usually covered by skin. And then with a myelomeningocele, we actually have part of the spinal column in it. So this is the most severe. So a lot of times ultrasound can pick this up if it's going to be severe. Alpha fetoprotein can also be elevated and illustrate that there's going to be some issues with spina bifida. And after birth, they'll be looking at an MRI or a CT to see if that pocket is just fluid or if it has spinal cord in it. We want to make sure that we keep them in the prone position. On the top of page 1311, remember, okay, so how I remember prone is prone position, you're prone to get something stuck in your butt. Sorry, but that's how I remember it. You'll never forget, right? Prone position, you're laying on your stomach, somebody's going to stick something in your butt. Right? Makes sense, right? So we want the hips slightly flexed. If you look at those pictures on 1311, it shows that the hips are slightly flexed. They've got them kind of tucked up under them a little bit. The legs are abducted, pulled too. And then it doesn't show it on the picture, but we want to cover the sac with sterile, warm saline dressing. Sterile saline, sterile dressings, moisten it, put it over that sac. Keep it moist. Keep it damp. Some people don't like that. Monitor for a cerebral spinal fluid leak. Anytime we have, okay, so a couple of things I'm going to throw out here. Anytime we have brain injury, anytime we have an issue with neural tube defects, and we have just a, if you look at those pictures, it's just a very light covering of skin or tissue over that, very easily could be damaged, right, and broken. Cerebral spinal fluid leak, what does that look like? It's typically a clear fluid. However, when it goes to a dressing, it'll look like a pale yellow, and it may have a darker center and look like a halo. Okay? It looks like a halo, so it's like a pale, very pale or clear. It's a clear drainage. Looks clear when it comes out of them. But if you look at the tissues itself or the dressing, you're going to see pale yellow with a little bit darker center, and it looks kind of like a halo around that dark center. And you can see that on any type of dressing. You see that on a dressing of any sort, be it after brain surgery, be it with a brain fracture or anything like that, increased intracranial pressure, whatever, if we suddenly see this drainage, we need to call the surgeon because it needs immediate attention. You don't want a leak of cerebral spinal fluid. Okay? Damages the brain, causes issues, not a good deal. So that requires immediate attention. All right? Monitor their neuro status. These are infants, but you still got to watch their neuro status. Vital signs, INO, and they're probably going to have a catheter. Provide skin care. Prevent joint contractures. So even though they're laying on their belly with their knees abducted, we still want to, or slightly flexed, hips slightly flexed, knees legs abducted. We need to do some range of motion so that they don't get stuck like that. Well, recognize that our hope is we'll get them to surgery pretty quickly. Yes, our goal is to get them to surgery and get it repaired. So we want to prep for surgery. We're going to get informed consent. But there are things that we have to also prevent and protect, because it could be, depending on the stability of the infant. Do they have good respiratory drive? Do they have neurostatus issues that we have to address before we can take them to surgery? So we may have to get them stable before they can go to surgery, and so in that case, we want to make sure that we're preventing contractures. But even after surgery, they're going to probably still have to be on the prone position for a while that heals, or on their side. So we'll want to make sure we're still doing some exercises with them. And, it's just like with any adult or child that has the potential for contractures, we're going to want to do those passive range of motion at least 2 to 3 times a day. We also want to make sure we're evaluating if afterwards, and what do their hips look like? Will they need orthopedic devices to help them with their malformation of their hips or whatever? So feeding these infants, again, we're going to have them in the prone position, so we have to be careful with that. We want to make sure if there's any pain after surgery, and we're dealing with pain control. Collaborate with specialists and therapists in physical therapy and occupational therapy. They're going to go in and do a repair, the laminectomy, and repair it and fix it and do what they can. We'll make sure that they stay prone or sidelined. We're protecting the incision site. Pre-op intervention. Recognize that a lot of children with spina bifida have allergies to latex. So we don't need everything latex-free when it comes to spina bifida. Make sure the parents are educated on latex-free. We want to make sure that the surgical room is latex-free. Okay. Educate. We want to prevent hyperthermia. Recognize that a lot of times these babies are laid out in a warmer. So we need to be monitoring that, making sure they're not getting too warm, because that can increase, if they get too warm, it can increase the cerebral function of the brain and metabolism, and we can have issues that way, plus it'll dehydrate the sap, so we have to be really careful that way. Maintain good glucose levels. Glucose helps and aids in in healing. And monitor and see if they have seizures, if you need seizure medications, and again, educate prenatal moms to take at least 400 micrograms of folic acid in their diet every day, and before they even get pregnant is best. Again, we have an infant that's been born with issues, and so this baby's not perfect, so we've got that grieving process you want to support. There's your latex-free environment. Make sure we avoid those foods, and we educate the parents on the need to avoid those foods, referrals, and anticipatory diets. Teach, teach, teach. Spinal cord injury. Yeah, it can be lifelong, the allergy to latex, yes. Most of the time it is, yes. Okay, we want to make sure we're educating on it. Not something that changes just because we do surgery. All right. The textbook goes into spina bifida and has a lot of information about it. So again, focus on the nursing interventions. Recognize that it depends on the severity of care, of the severity of the defect, and know your general information, pre, post-op, education, those types of things. All right, and my pages. (1327) is where spinal cord injury begins. Page 1327. These are most. Did we have a question? I heard something. Yes, no. All right. 1327. And these are most often seen in summer when kids are diving into shallow pools of water, falling off out of trees, falling or turning upside down on ATVs, getting in car accidents. Just people are more active in the summer, and so we have more spinal cord injuries. Can also be associated with traumatic birth, and can also be caused by violence. Typically, a spinal cord injury can involve one or all regions of the spinal cord, so just one section or all. There are 4 types. There's a cord resection, a cord laceration, a cord contusion, and cord injury. A resection basically means it's completely separated. Laceration has been cut. It may not be all the way, but the spinal cord has been cut somehow. Contusion, the spinal cord is bruised, or just a cord injury. There are 3 phases of a spinal cord injury: acute, secondary, and chronic. Depends on the severity of the injury and how that's going to be. So I'll go through those phases, but there may not be a chronic or a secondary. If it's just a small injury, once the swelling goes down, everything goes back to normal. Signs and symptoms just vary on the level of injury. Where is it injured? Along the spinal column, what's it going to affect? If something is injured in the neck, it's going to cause more problems all the way down, right? If it's in the low back or the lumbar spine, you're not going to have as many issues as you do in the cervical or up in the neck. Thoracic, same thing. Just depends on where it's at, okay? But all of them, you can have issues from wherever the injury is, from that point below or down. You can have loss of spinal reflexes that can cause vasodilation, hypotension, bradycardia, and spinal shock. The severity again depends on, is it a complete spinal resection or is it just partial? At any level you can have increased muscle tone, loss of bowel and bladder. It doesn't matter what level of the spine is injured. You can have increased muscle tone, muscle spasms, that type of thing, attention, loss of bowel and bladder control, numbness, sensory changes, pain, weakness, or paralysis. If you have a spinal injury of any kind, you can have some of these symptoms. It doesn't matter where it is. Tetraplegia is the new term for quadriplegia. So all 4 extremities, both arms, both legs, and paraplegia is an injury to the thoracic, so lungs basically, or lumbar or sacral. So basically it's just the bottom, the legs. Usually this is determined through clinical assessment and x-ray. You'll do an x-ray spine series, CT scan, MRI. With the tetraplegia paraplegia, there's going to be some diagnostics with sensation. Poking on, do you feel this? You know, kind of thing. It's really just a matter of what you feel and what you not feel, as well as relational to what you see on x-ray or CT or MRI. Airway management. They may have to have a trach, and they have to be put on a ventilator for the rest of their lives. If they don't have muscle control, can't control their diaphragm, they're not going to be able to breathe on their own. So we need to make sure we're monitoring airway management. Circulation, we're going to do IV. We may do fluid resuscitation if we see bradycardia, the hypotension, and some signs of shock. We may have to do some fluid resuscitation, but we're also going to have some strict INO. We don't want them to get fluid overload. And we will do a Foley catheter. We're going to monitor their cardiovascular system, disability identification, immobilization. We want that spine to stay stable and in proper alignment while it heals. Skeletal traction, halo traction. Administering medications. We're going to use steroids to reduce inflammation. We're going to give pain medication. Emotional and social support, maybe surgery, just because of what's going on there. And, you know, if we can repair it with surgery or do things to help with surgery, we will. But if we can't, we won't. But think about your surgical repair and what you would need to know for that. And then education prevention, there will be extensive rehabilitation for these children. If you look at page 1328 in your text, it gives you a table that indicates different types of spinal cord lesions and what you can see, what it'll look like. You don't have to memorize that. Guys, I'm not going to ask you this injury, what level were they affected. I'm not going to ask you that. Generalized questions. What do we need to watch for? What do we need to do? How do we anticipate what we're going to have to care for in this situation? That type of thing. All right? So look at your nursing care management. Our patient outcomes, we really want their neuro status to improve. We want them to get back to normal if possible, or sustain no further injury. So we don't want them to get bed sores. We don't want them to get infections. We don't want them to have issues, right? So prevention of complications. Again, support resources. Is this going to be a short-term thing or a long-term thing? Sometimes with just spinal cord injuries, they can heal. Spinal cord does heal and regenerate. So it takes a long time, but it may be short-term. You know, we think short-term, 3 to 6 months. Long-term for life. Okay. Brain tumors. Brain tumors are the second most common cancer in children. This starts on page 1091 in your text. So we're kind of backing up, 1091. So this is chapter 29. There's not a lot of information on brain tumors. And the main thing to know is it's going to cause increased intracranial pressure, right? Unless their head is not, unless they don't have the below 5 years of age, right? Because their head can give, but we'll see an increase in their circumference, their head circumference. All childhood brain tumors are primary tumors. In other words, it's not a metastasis from somewhere else. It's a primary tumor. So the assessment really is going to depend on location, tumor type, and age of the child. We're going to assess their intracranial pressure. We're going to monitor for increased intracranial pressure. We're going to look for any obstruction of the cerebral spinal fluid. Monitor their head circumference. The tumor has to be staged. There are different ways to stage brain tumors in children. Sometimes we don't want to do surgery until we know what we're doing. So a lot of times it'll be MRIs, imaging, CT scans, those types of things. We may do a biopsy if that's the only way we can find out for sure, because that's the only way to garner that tissue. But sometimes the location of the tumor, those types of things can tell us what type of tumor it is. And sometimes we don't find these things until they're progressed in children because their head circumference can give. It may be a change in pupils and eyes that indicate an issue. Maybe a change in, Stacy talked a lot about that too, with how her son, his speech didn't come along and he just wasn't acting himself. He was irritable, and that's when they found, and he has a growth in his belly, right? So sometimes there'll be a metastasis that will actually be an indication where that brain tumor spawns somewhere else. So that can be a place that can be biopsied outside of the brain if you don't want to get into the brain. And sometimes the reason for that is just if you think about tumor seeding, and sometimes what that means is we go in to get it all, the brain tumors. This type of childhood brain tumor can be very fragile. And so when they go in to take it out, sometimes it falls apart. And as it does that, pieces of that tumor
fall into other unaffected areas of the brain and can seed that cancer to another area of the brain. Does that make sense? So we have to be really careful and not do anything until we know we need to, but it has to be staged. We're going to make sure that we're doing neuro assessments frequently. We're doing airway management. We're doing pain management, psychosocial. We're dealing with the effects of this parent being told the child has cancer. That's talk about blood, right? Once the tumor has been staged, then we're going to look at a plan of care. Plan of care. What are we going to do for this child? We're going to do chemo, we're going to do radiation, we're going to do both, we're going to do surgery. That's when the plan of care is determined. Think about pre and post-op brain surgery, watching for increase in cranial pressure, watching for infection, watching for cerebral spinal fluid leaks, yada yada. We may give IV steroids to reduce inflammation. We may have to give anticonvulsants, constant neuro assessments, airway management, fluid and electrolyte management, prevention of infection, manage pain. So there was a couple of questions I just want to, on discussion board, I'm going to address real quick. Question were increase in cranial pressure and IV fluid. Think about your types of IV fluids, whether it is hypertonic or hypotonic. Those types of solutions, either increase fluid in the tissues or increase fluids in the vascular space, right? Hypotonic or hypertonic, right? It's either going to push fluid into the tissues or it's going to bring fluid into the vascular space. Either one of those can increase the pressure in the brain, right? Because you could increase the tissue, fluid in the tissue, which increases that pressure, or it's increasing vascular space, which then also increases. So really, if we're going to do any type of IV fluid, we're going to be isotonic. Okay? And then pain. Yes, these kids, whether it's a trauma, sustained injury, traumatic brain injury, whether it's surgery, they're going to have pain. The brain is extremely sensitive. I don't know how many of you have ever experienced a spinal headache. I've had 2 or 3 in my life. Every time somebody sticks a needle in my spinal cord or spinal column for whatever, usually lumbar, or like to do a myelogram, it doesn't matter. I have a tendency to get a spinal headache and form a leak. And I have to go back in there for the blood patch. But let me tell you, your brain is full of nerves, nerve endings. And when you don't have that cushion of cerebral spinal fluid, or you have too great or whatever, your brain, the nerves on your brain scream at you. And they say, pain! And you gotta have something. These kids hurt. We do need to give them narcotics to help with their pain, but we know the side effects of narcotics versus the signs of increased intracranial pressure. There are other things that we can look at. We can watch for that widening pulse pressure. We can watch for pupillary changes. We can watch for more sedation than what the medication would be given. If they're not arousable through a painful stimuli, then we have a problem. It's increased intracranial pressure, not narcotic. Unless the respiratory drive is down as well, then it may be narcotic. And we just start with Narcan and move from there, right? But we still need to give these kids narcotics because the pain is severe. All right. Adequate nutrition, maybe TPN or NG feedings. Promote normal growth and development to the best of our ability. Communication and support. Keep lines of communication open, support, resources, all of that. Recognize there may be some issues with lifestyle that changes. If somebody's going through chemo or radiation, we want to watch for infection control and all of that stuff. Psychosocial support, home support, if it's a short-term thing or long-term thing, and what needs to be taken care of, and then resources available to them. Developmental disabilities. This starts on page 632, so we're back on our even further. This is chapter 20, I believe. 632. And I am still recording. All Alright, so there's a number of developmental disabilities that are out there, wide variability of classification. Many will co-occur with some physical conditions, and maybe genetic, maybe metabolic, maybe pregnancy-related problems or trauma at birth. What's initially called mental retardation can be severe or minimal. And there are 3 criteria for diagnosis. So, and they're really trying to get away from the IQ test, but they're still, right now, kind of putting that in there as a criteria, but it's an IQ significantly below average. Recognize that 100 is about average. So, and then limitations in functions of daily life, and an onset before the age of 18. There's mild, moderate, severe, and profound. So, nursing interventions really are determined by how severe the disability is. We want to make sure that we provide care at the cognitive level. So if you have a 14-year-old that's functioning at the age of a 2-year-old, or a 3-year-old, or a 4-year-old, you're going to educate and help them with their care according to their cognitive age level. Okay? So even though they may chronologically be 12, but they function as a 3 or 4-year-old, and they're getting ready to go to surgery, you need to explain that surgery as you would to a 3 or 4-year-old. Bring in a doll, show them what's going to happen with the doll, illustrate as though you're talking to a 3-year-old, not a 12-year-old. Does that make sense? So again, those communication things we talked about in the growth and development lecture, ding, 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 look back at it. Communicate with the family about treatment. How can they help their child to be all that they can be? What treatment is necessary? Look into genetic counseling and therapy if necessary. If the parents want to do that. Some do, some don't. Just because of whether this is something that can happen again, and we're going to go into that here in a few minutes. Education, promote good prenatal care. A lot of this can be prevented with good prenatal care, immunizations. If somebody gets, if a pregnant woman gets rubella, she can have some issues with intellectual disabilities with the fetus. So that's why we promote immunization. Safety, support, and resources. Down syndrome is a form of cognitive disability. We have poor muscle tone, slanting eyes, hyperflexibility, short hands. They're very broad. They have a single crease across their palm. Maybe on one or both hands. They have a flat bridge of their nose. Usually their ears, when you think about ears and eyes, if you draw a line from the ear to from the eye to the ear, it needs to be about level. With Down syndrome, it's going to be lower than that. The ears will not be at the same height as the outer canthus of the eye. It'll be lower set. And they'll be short and smaller. They may have heart defects. They can have GI anomalies. They may have eye problems, hearing problems, and they can also have an issue with their thyroid. Chromosomal blood test tells us that they have Down syndrome. Activity 23. Or 21, sorry. So basically, Down syndrome is an extra chromosome, 21, so it's called trisomy 21. So there's an extra chromosome in there that shouldn't be there. And that's how the lab diagnostic comes and says, yep, that's what they have. We want to be sensitive to the parents' needs. We want to help them adjust to this diagnosis. We want to promote early intervention, which may be physical therapy, maybe occupational therapy with this infant. We want to ensure that care is geared toward physical, developmental, and emotional needs. So basically, all encompassing, right? We want our
our nursing care to be all-encompassing and address the physical, the psychosocial, the emotional, all of that, and so does this care. Coordinate programs, help families cope emotionally, provide resources, collaboration. And the other thing is for Down syndrome kids, they need interaction just like any other kid. They need to be in school and have interactions and be supported and be encouraged to reach their maximum. And recognize that Down syndrome can be from very mild to more severe. Again, just varies from child to child, what that's going to look like for that child. Fragile X. Fragile X syndrome is a genetic trait that is carried from generation to generation. And so this is one that you might want to do if you have a child with Fragile X syndrome. You might want to go ahead and have genetic testing done. It is the most common inherited cause of cognitive impairment, and the second most common genetic cause, second only to Down syndrome. So, Fragile X syndrome, they have a large head, elongated face, prominent ears, chin, and forehead. They do have developmental delays. They'll have some social and behavioral difficulties. There is a family history, and we also need to look at prenatal issues. DNA test will tell what it is. It does affect 1 in 3,600 boys, 3,600 to 4,000 boys, and 1 in 4,000 to 6,000 girls. But they can be carriers as well. So even though they may not have it, they may be a carrier of it. It is caused by an abnormal gene on the lower end of the long arm of the X chromosome. That's in the textbook, I just read it to you. All right, so assist with identifying the Fragile X syndrome, educate, support, and refer to community resources. Clinical manifestation 640, page 640 in your text, box 23 is there as well. Hearing disorders, they can be genetic, non-genetic, idiopathic or caused by disease process, fluid accumulation in the middle ear, contributing factor for children, structural anomalies of the inner ear, outer ear. There's all kinds of things that can cause hearing disorders. So one of the things with hearing disorders, we do a lot of screening for hearing disorders, but screening does not prevent, right? Screening recognizes. Just like screening of breast cancers through mammograms and MRIs and those types of things, it helps for early identification, but it doesn't prevent it from happening. So screening and doing the infant hearing test in the hospital don't prevent it, but it does help to find it early. And we'll see that with a lack of startle. They don't turn when they hear a sound. They don't answer their name. They have delayed speech. Their speech may not come out appropriately. Maybe garbled. May not make sense. Those are usually ways we can tell there's issues with hearing. Hearing loss can be prevented because we can do immunizations, because a lot of hearing loss comes from disease process either in the mother or the child. Immunizations can prevent hearing loss disorders. Okay? So based on underlying pathology, what's going on, we're going to make sure that we take care and address and intervene if we can. Sometimes we can with the hearing aids and cochlear implants. We may find ways for communication for those that we can't, so learning sign language, those types of things. We want to make sure so they're able to communicate and we can communicate with them. And so we want to make sure that we promote communication. And then provide emotional support for the family. Again, safety. If you have a child that can't hear, there are things that we hear that tell us there's a problem. Oncoming cars, fire alarms. You know, they've gotten now where you have the flashing lights too. And that's for those kids that are hearing impaired, they can see the flashing lights and know there's an issue. They may not be able to hear the siren. So, prevention, again, through immunization is the best way to prevent hearing loss. Vision disorders. Blindness, retinopathy of prematurity. I promise I'm finishing right now, as quickly as I can. Miss Briggs, I'm hurrying. Retinopathy of prematurity is, okay, so there's Fragile X, page 639 towards that. Hearing disorder, 640. Is hearing disorder. Now make sure that you look at page 643 for hearing disorders, page 643, box 20.4. Clinical manifestations of hearing impairment. There you go. Page 643. Page 645 starts your vision disorder. Need more coffee. 645. Full blindness, retinopathy of prematurity. I have a page number for that. We'll get to another box about it. Okay. So, refractive disorders, hyperosia, farsightedness, myopia, nearsightedness, astigmatism, which is where the lens is not perfectly round, it's more spherical in nature. Amblyopia is a lazy eyes for business, cross-eyed. All those are there for you. Astigmatism, involuntary eye movement, cataracts. Glaucoma is increased intraocular pressure. Intraocular pressure in the eye. Interesting story. My sister has glaucoma, and what it is actually the color in her eye leached out. She used to have a really dark circle around her in her pupils, and very, very rare form of glaucoma was found when she was younger, and that color pigment actually leached out of her eyes. She no longer has the dark circles. Her eyes are actually very pale now. Rare form of glaucoma where the fluid, the color of her eye seeped into her eye, causing an increased intraocular pressure. Rare, weird, but it happens. Eye injuries, foreign bodies, penetration, edema, chemical burns. Page 645 and 646, box 20.5. 645 and 646, box 20.5 is going to talk about your different types of visual impairments, everything that's listed there, what it looks like, the pathophysiology of it, the clinical manifestations, all of that information is there. Do your visual exam. If they're squinting, that's usually an indication that we have some visual problems. Do they have headaches or migraines? That can also be common causes for headaches, can be visual disturbances. They're trying to focus and they can't, so they get headaches or migraines. Make sure that you provide intervention, support, collaborate with a specialist or therapist as needed, and promote optimal development. Retinopathy of prematurity is found on page 315 and 316 in your text. 315 and 316. Basically, this is your premature babies that are born, and they get an overexposure to oxygen, which causes an issue. It's actually, it causes visual impairment to complete vision loss. Immature blood vessels in the retina constrict because there's so much oxygen. They constrict and then they die because they're so tiny. And so they don't have blood flow to the eye, and so then, or to the optic nerve, and so then you lose vision. It can be treated with therapy or surgical procedures. You want to minimize the exposure to light on your preemies and titrate your oxygen very, very closely. Foreign bodies, and this is on page 647. There's an emergency treatment box there on page 647. I would be familiar with how we treat these different injuries to the eyes. So So penetration, we're gonna get them to the ER to remove whatever's penetrating their eye, corneal abrasion. We may give topical antibiotic solutions or ointments and an eye patch to keep it hydrated and prevent infection, those types of things. Hyphema, it's hemorrhage to the anterior chamber of the eye. There's not a lot of treatment for that. It goes away on its own typically. Rest. We mind if it's severe and it's causing increased intraocular pressure, glaucoma. They may have to do an evacuation, but not usually. But they do want to watch for that if it's severe. And keep the head of bed about 30 degrees. And then patch both eyes. If you only patch one eye, your other eye is still moving. And if your other eye is still moving, what's that doing to your patched eye? It's moving too, right? So it's not resting. So you have to patch both eyes so that neither eye moves. And that's how you get the rest. Chemical burns. And we want to make sure we're flushing their eyes for 15 to 30 minutes. We know what the chemical that they have been burned with and what the pH is, and we need to take them to the emergency room. Because sometimes there needs to be more than what we can do with just flushing. Again, eye patching, you want to do both eyes so that both eyes can rest and the irritation does not happen to the eye that's got the problem. And we may give antibiotics to prevent infection. All right. Whew. I promise, Ms. Bruce, I'm almost there. Autism disorders. This is our last slide, page 650 in your textbook. Typically, these are diagnosed or seen or start to appear around age 3. And a lot of times what I have found with research on my own is around age 7, once they start to school, that they do get diagnosed. That they can start to see issues around age 3. There will be with this disorder, you'll see that there's some limitation in social relatedness, how they relate to people, verbal and nonverbal communication, and then a range of interests and behaviors. It can be from OCD to withdrawal to just very different behaviors that are kind of bizarre. I say different. Bizarre is the best word. You'll see an impairment in social reciprocity. So we know that with children, they have a tendency to imitate parents, right? At a certain age, when they're 3, 4, 5, they'll imitate, they'll reciprocate. You smile, what do? They smile back, right? It's that reciprocity. I can't say that word. They reciprocate. They do it back to you. With autistic children, you don't see that. They don't do it back. There'll be some communication impairment. There may be restrictive or repetitive behaviors, extreme interest. They become obsessed with things or activities. Repetitive, they do the same thing over and over again. The main thing is we want to make sure that we promote early intervention and treatment. We want to continue language development and help them to get to the very best that they can be. We want to, autistic kids don't really play well with others. They like to play by themselves a lot of times, and that's okay. They also really need structure. Any of your kids with developmental disabilities need structure. So they need their medications given at the same time every day, whether they're at home or they're in the hospital. They need that routine. Your autistic kids need that routine. So if they're in the hospital, we want to maintain their routine to the best of our ability. And one of the ways we can do that is through medication administration, meal times, certain television shows they watch every day, whatever. We're not going to say they have to go to a playroom with a bunch of other kids, but that makes them uncomfortable. We're going to really just we want to encourage social competence. We want to help them to facilitate that, but we're not going to pressure them into that either, because that can sometimes just cause further acting out and issues. Stay aware of their physical boundaries. Autistic kids a lot of times don't want to be touched, so you need to be careful with that, and you have to ease into it. And so you have to ease into it. You have to start talking to them first. You need to tell them what you're gonna do. And then education and family support.
All right, guys, I've thrown a lot at you. I have tried to reiterate things that you needed to know for the test. I've tried to go back through and talk about things that I missed or things that I wanted to make sure you understand. So I hope that I've addressed all that. If not, watch the discussion board, because I might post something if I go back and say I know because I rushed through this. Hey guys, make sure you look at this page or whatever. I might do that. So you might want to make sure that you check the discussion board on Monday.